Hello. Again, I'm Donovan Bigelow, and this is part two of Psychopathology. I'm going to talk now about the way Nancy McWilliams diagnoses, the way she thinks about the human mind. And in her second edition of her book, Psychoanalytic Diagnosis, there's a small chart. It's on page 96. And in it, she lays out a vertical and a horizontal axes. There's the Diagnostic and Statistical Manual. They have their 5 axes. Well, she's got her 2 on a chart. And I actually have this chart in my mind. I've read it so much, I've read about it so much, I've used it so much, that when a new patient comes into my practice, I can just imagine this sort of in my mind, and it helps me figure out where the patient is. So here's the way she describes this chart. And we're going to go through every element of the chart in detail. I think this is one of the most useful diagnostic tools. I think it represents one of the most sophisticated and useful. Remember, that's what Nancy McWilliams' goal is. Not to represent with perfect scientific accuracy the human mind and its functioning, but to be useful. And does this really help patients, help clients? Does this really help clinicians, help patients get better? That's the question. And here's the chart's basic description. The essential character structure of any human being cannot be understood without an appreciation of 2 distinct and interacting dimensions: developmental level of the personality organization and the defensive style within that level. Those are her 2 axes. What is the structure of the human mind? What is the structuralization? How stable is the structure? And across the horizontal axis, what is the defensive style? How does the patient use defense mechanisms to manage internal and external anxiety? If you understand those 2 elements of the human mind, you will almost always accurately diagnose and therefore be able to help your patients. Let me go through the details. Before I get there, Nancy McWilliams told a story once of walking outside of her home and running into one of her neighbors who was not a psychologist or psychotherapist. And he asked her, "What are you working on today, Doc?" He knew she was a psychologist. And she says, "Well, I'm working on this book about diagnoses. And it's complicated." And he said, "I always thought there were just 2 categories. I always thought it was just real simple. You're either nuts or you're not nuts." And she laughed and they had a good chuckle. And she said, "Wait a minute, no, I understand what you mean, but it's really more like this. How nuts, and nuts in what particular way?" That represents, in a funny but really sort of amazingly accurate way, her way of thinking and her chart. So structure. How structuralized is the human mind? She categorized 3 things in 3 ways: neurotic, borderline, and psychotic. That reflects the standard structural division going back 100 plus years. Neurotic, what does she mean by that? Well, Freud said at one time, "I'm a neurotic." And it wasn't a good or a bad thing. It was just the way he thought high-functioning people whose minds had been developed with good enough parenting, whose identity had firmed up. Now, I got to say, in order to understand this part, you almost have to have looked at the child development material, because this is all grounded in how patterns of mind get developed through birth to 3 or 4 or 5 years of child development. If you've looked at those lectures, this will make sense. If you haven't, you're going to be a bit lost. Be that as it may, my assumption is you've had some familiarity with child development in the psychoanalytic model. Okay, back to neurotic, at the top end of her structural axes. When Freud said, "I'm a neurotic," he wasn't accusing himself of anything. That's as good as it gets. There is no perfect health. There is no human being who is without conflict, without issues, without struggles at some level. But the neurotic is the one who has achieved a certain stable structure of mind. Their identity is stable. They may have lots of emotions, but their identity doesn't fall apart under stress. They don't make wild swings of behavior. More or less, they're identifiable as who they are. to others and to themselves, and they are consistent over time. Their identity doesn't fall apart under stress. So high functioning neurotics, that's as good as it gets, folks. Maybe in another world it'd be nice if we could achieve perfect health, but it looks like, given the messiness of human nature, being a high functioning neurotic is as much as we can hope for. It certainly was all Freud could hope for. So what does that really mean? All right, identity integration, object constancy, that idea that our sense of our internal experience of ourself is stable over time. Now, everybody has a good day, everybody has a bad day. That is within these parameters. Do you, however, under stress, even severe stress, have a tendency to fall apart, become delusional, not be able to function in reality at all? If you have those dynamics, you're down on that structural scale quite a bit. The high-functioning neurotic deals with their conflicts internally, deals with the stressors in their life and their relationships, and can be seen and sees themselves as mostly a stable human being. Okay. Next category down, what's now known as the borderline category. McWilliams describes this as mostly high-functioning most of the time. That most people who are borderline get through most of their days in ways that seem an awfully lot like high-functioning neurotics. The difference is this. The difference that is when their primary relationships get threatened, they tend to fall apart. Now, they do reconstitute, they do reintegrate, but around questions of primary relationships, when a partner threatens to leave, when someone is lost, they tend to decompensate. They tend to fall apart and experience what almost seems like a complete psychotic breakdown. The difference is that they're not there for very long, 24 hours, 48 hours, and you find borderlines, by and large, coming back, reconstituting, and frankly, not really understanding what the problem was. That's one of the elements of the borderline category. We'll go into the details a little bit later. But they don't have a particularly sophisticated psychological mindedness. They don't get what just happened is often quite traumatic for those around them. But that's the key differential between neurotic and borderline, is that under stress, around questions of primary relationship, the borderline can decompensate all the way to psychosis. All right, psychotic, that's pretty obvious. Most people know severely crazy when they see it. People who hallucinate, people who are delusional. This is what, the schizophrenics who often are seen wandering around talking to themselves, disheveled, unkept, don't do self-care at all or nearly as well as they should. The overtly psychotic, dominated by hallucinations and delusions. That's the key symptom. If you're at that level, the McWilliams structural dimension means that you don't really have a mind very well or very much. That your structure of self is fragmented structurally. You've fallen apart. More likely, developmentally, you never really came together to begin with. Most people think that schizophrenia and the severe psychoses do have their source in do have their etiology, their cause, in very early traumatic childhood developmental failures. And so the sense of object constancy of the neurotic, which forms in development around 3 years, give or take, simply never took hold in psychotics. And they may get through their early childhood or adolescent years contained by the structure of a family. But once they get out, what we find is that schizophrenics become schizophrenic quite frequently, between 18 and 23, 24 years old. The lack of structure in their minds breaks out when they lose the structure of their family that was keeping them together. So that's the vertical axis. Neurotic, borderline, and psychotic. Together most all the time, together until they have significant stresses in their family or in intimate relationships. The psychoses represent a fundamental failure of self-structure. Now, It's absolutely essential that therapists diagnose which they're dealing with, because you do not work with a neurotic the same way you work with a psychotic, obviously. And if there are borderline dynamics and you don't recognize them, you misdiagnose them, you are likely to have a very short therapeutic experience. They don't last very long if you misdiagnose them. So, how to tell them apart? And McWilliams, on page 48 of her text, gives us a thumbnail sketch of the key issues that helps us understand. Now, why would a patient want to know this? Why would a student want to know this? Why would a lay person want to know this? Who are you around? Are you in relationships? Wouldn't you like to know something about the person you're dealing with? Whether it's a coworker, a friend, a potential partner? I think this material can be absolutely essential for every layperson in looking around their own lives and deciding who they want their friends to be, because you shouldn't diagnose your friends. If you're a layperson, you're not a clinician, you haven't had the training. But I think this material might be really helpful if you could keep the basics in mind. If you see symptoms that reflect psychotic or borderline functioning, you might not want to marry that person without a significant amount of therapeutic intervention. So here's a thumbnail sketch of how to, at least in gross terms, tell the difference between a neurotic and a psychotic or severely borderline person. When you're talking to them, or when they come into therapy, if you're a clinician, has there been an identifiable precipitant? Has there been something, an event that caused them to come in to get treatment? Or is this something that's just been around forever as part of their life? Do they feel like this problem is just the way things are? You have, on the one hand, indicators of neurotic symptomology. This is a new problem. It's a new conflict that we have to deal with. There isn't a long history of this kind of difficulty. That suggests neurotic functioning. If this difficulty has been pervasive in their lives, then we've got something that feels more like a character disorder. It feels like it's lower down on Williams' structural chart. Has there been a dramatic increase in the patient's anxiety? Well, that goes along with number one a little bit. Is there a significant change in the person's circumstances that resulted in what seems like an event or a crisis that causes the person to come into therapy? Or the alternative in number two is, has the person just felt an incremental worsening over time of their symptoms? If there isn't a dramatic increase in anxiety, if the person is just sort of slowly falling apart, then that suggests, again, more structural problems. Is the patient self-referred? Does the patient come in because they have some sense that, I have an issue here that I need to work on? Or are they sent by someone else? Are they sent by a spouse, a family, the court system? That's a strong indicator of more serious structural pathology. How does the patient see the problem? Are the patient's symptoms what we call ego alien? Or, in the more severe cases, are they egosyntonic? And what that means is simply this. If the patient comes in and says, Mr. Bigelow, I've been doing this thing. I've been drinking a little too much, and I know I shouldn't. I know it's hurting my family. I know there's something wrong with the way I do that, and I want some help fixing that. That's what we would call an ego alien symptom. The patient knows there's something wrong, knows there's something wrong inside of them, and is coming to seek some help to fix that internal problem. If the patient comes in and says, I know, Mr. Bigelow, I drink too much, but I'm a cowboy. That's just my culture. That's just the way I am. Can you help me get my wife off my back about my drinking issues? Because I think I'm just fine. Okay, right away we've got a big problem here. Now, maybe it is a problem, maybe it isn't. Maybe it's the wife's problem, or maybe it's some conflict or failure to communicate between the two of them. All that's possible. But if I see a patient doing destructive things and they don't think it's a problem, that puts them lower down on McWilliams' structural axes. That says something about the way their mind is structured. They don't have the ability to recognize themselves in relationship with others. They don't have a sense of their identity clearly or accurately enough. The final little thumbnail that I think is very useful for everyone is that does the patient come in, or does the person have the ability to form some kind of meaningful relationship? Can they be a patient in a therapeutic alliance with the therapist? Can they be a fairly decent friend? Are they a fairly decent, consistent lover, if that's the nature of the relationship? If that's the case, and there are other conflicts that have to be worked on, that's an indication of a high-functioning neurotic, of a mostly well-structured identity. If there is a fundamental problem with the nature of their relationships, if they don't relate well or adequately, if they don't relate well, if they don't have friends, if they don't have intimate relationships, if they don't see the therapist as someone they can work with in a relational dynamic, again, that puts them lower on the scale of McWilliams' structure. Next three issues. And this is going to be a problem for everyone thinking about diagnosing a patient. There is frequently a conflict between what the therapist thinks is necessary and what the patient thinks. And this is an example of how clearly the medical model doesn't work very cleanly. As I said before in the previous lecture, when I had an appendicitis attack, I was on the doctor's team. We were together. We were on the same team trying to fix my problem, and I was doing everything in my power to give him all of the data I had honestly. I have never once in almost 15 years of practice had a patient come in and be honest with me on the first day. Not because they're lying, but because the truth is they don't even know what the problem is in any great detail. Sometimes they can't handle the truth. Sometimes they do in fact lie. Sometimes they've massively repressed what the problem is. And very frequently we get what appears like a conflict between what the patient wants the therapist to do and what the therapist thinks he or she is able to do given the patient's material. That conflict rarely happens in the medical model with real physiological problems. That's something the therapist has to constantly be mindful of. If the therapist mistakenly treats the patient as a medical patient and accepts as true everything the patient says up front and just runs with it, the therapy will be a disaster. It cannot work that way. Because that's a simple fact of the functioning of the human mind, not brain, mind, is that patients really do not understand much, and sometimes most, of what's driving the difficulty in them and their relationships. The next thing that gives the McWilliams way of thinking about this an advantage is that depending on where you are on her structural axes, you must recognize a different approach. A medical doctor dealing with an appendicitis is going to treat almost every patient exactly the same. Get the scientific data, do the scientifically proven methodology for establishing the physiology of the person and its problems, and then execute the scientifically confirmed procedure or method to fix the problem. No medical doctor, no internist looking at the possibility of an appendectomy is going to do things very much different. Maybe 5-10% they have some stylistic differences, but the scientific methodology is sound, accepted, and universal, at least in this country. That is not going to be the case in therapy with a patient. The nature of their mind, the nature of their sense of identity or their identity is going to determine how the therapist reaches out or whether he or she can reach out at all to the patient. Sometimes, if the patient is very disturbed, the therapist has to be very gentle, very calm, very still, not do very much at all in terms of interventions, being careful how they make interpretations. because you can scare the patient away. They cannot tolerate much anxiety. Interpretations of an aggressive sort, or of the kind that might be perfectly appropriate for a neurotic, high-functioning patient, will drive a more disturbed patient out of therapy almost immediately. So one has to diagnose accurately in order to establish a firm and lasting working alliance with any patient based on where they are, and that varies quite a bit. It's not like the medical model here at all. The other thing that the therapist needs to know is the simple fact is that not all patients are equal, that those patients on the more disturbed end of McWilliams' structural axes are always much more hard to deal with. They're much more often aggressive. They're often inconsistent. They have wild mood swings. They have sometimes overt hallucinations. To deal with a schizophrenic is profoundly difficult work. To deal with a high-functioning neurotic can be almost an enjoyable experience. Complicated, not easy, certainly, but it doesn't have the intensity and the feeling of almost danger in the room with a severely disturbed patient. The therapist needs to know what he or she is getting into, and looking and thinking about and struggling with where the patient is on that structural axis is central to the therapist being able to help the patient and not getting themselves, if you misdiagnose a patient on that axis, it's going to be almost impossible to treat them effectively even over a short period of time. All right, so let's look at the details of McWilliams' template. Now, the diagnostic manual has its symptom checklist. Not surprisingly, McWilliams has a bit of a checklist on issues that have to be addressed to determine where a person is on the vertical axis. Overall, in all three areas, she wants to look at the following things. What are their favored defenses? That's the first question. What are the defenses of the neurotic? What are the defenses of a borderline or a psychotic person? What do you see them doing to manage anxiety? The obvious question is, what is their level of identity integration? That's number two. Do you get a sense from their history that they're mostly together, or do you get a sense that they have been subject to psychotic decompensation sometimes? Third thing, how adequate is their reality testing? Are these people, is this a person who deals with reality adequately? That's a sign of a high-functioning neurotic. Is this person overtly paranoid? Is this person not connected to reality? Is what they're doing, are the symptoms they bring in suggestive of a person who is delusional, is not dealing with reality, does not see how things really are in the outside world? Now, I get we all have a problem with that sometimes, but the difference between a neurotic and a psychotic in their reality testing function is patently obvious to most clinicians. To the extent you are not dealing in reality very adaptively or very effectively, you are much lower on the scale of structure. Presence of an observing ego. This goes back to that idea of ego alien versus ego syntonic symptoms. Do I have inside me an observing ego? And what that means is there a part of me that goes, wow, I really messed that up. I shouldn't have done that. What the heck was I thinking? How can I do better next time? Okay, that's an observing ego. That's someone with a modicum of self-awareness and an understanding that I am bringing something to the relationship, that I am in some ways participating, co-creating in the relationship. I'm not an innocent victim. I'm doing something that's evoking part of the problem. I got to take responsibility. If you have that kind of a patient, you're on the higher end of the structure. What is the nature of the patient? This is number 5. What is the nature of the patient's primary conflict? And I'm going to talk about the details of this one a little bit later. But are they struggling over issues of sex and aggression? Are they struggling over issues of guilt around something? Now, those are pretty sophisticated questions. Are they struggling over whether or not they exist? Are they struggling over the question of their identity in a persecutory world? Are they crazy paranoid? All right. So the conflict, that therapists should be able to see fairly quickly will be an indicator, again, of how structuralized they are. The sixth thing that McWilliams comes back to in every one of these categories, on the structure and even on the horizontal defensive axes, is what is the transference, countertransference potential? And I haven't talked about therapy a lot, and I've only touched on transference in the classical lectures on psychoanalytic history and the basics. The short version is, what is the reaction in the therapist? What feelings are evoked in the therapist in their what we call countertransference? In the therapist's experience, how does the patient relate to them in the transference? How is the patient projecting onto the therapist images of his childhood developmental objects? That is a way we now understand as clinicians to really get some very important information about the patient. Can the therapist sit there and be aware of what's being evoked inside of him and her? I think that now is understood to be an absolutely essential function of a good therapist. What's going on inside of me? It's not just like a medical professional evaluating the patient. In therapy, it is the therapist, him or herself, very frequently, the very mind of the therapist, that becomes the key diagnostic tool. This is where psychotherapy and the medical model are radically worlds apart. Yes, in the medical model, the doctor, his knowledge or her knowledge and understanding and experience is used to diagnose the patient. But that's different in therapy than what I'm talking about. I'm talking about not clinical, scientific, rational judgment about data. I'm talking about an almost unconscious, barely able to be brought to consciousness, awareness of the therapist's own internal experience of the patient in what we call this projective process back and forth. What feelings are evoked in the therapist? That is important data for the therapist to have. And a therapist should wait, think, feel, recognize the patient's impact on them as part of their diagnostic workup. McWilliams comes back to this frequently, and she's absolutely right. In the last 50 years, it seems like most therapists, even those in the cognitive behaviorist field, even though they recognize that there's something going on here that has to be paid attention to inside the therapist. Okay, so let's run down the checklist for each individual section of the structural axis. Neurotic. Here's how she describes it. Accomplished separation and individuation, but having run into conflicts between things they wished for and things they feared. The prototype being the Oedipal drama. Again, you got to have the background of the child development stuff, or that's not going to make any sense at all. The short version is these folks have made it through the first 3 or so years of their life with adequate, good enough parents who have provided the children with as much love and care as they needed to grow into mostly integrated whole personalities, identities, a sense of the self in the child as stable. We get that child development, by the age 3 or 4, 90% of the child's identity has been laid down, bedrock, and frankly, it doesn't change very much after that. So the assumption in the neurotic model is that those early childhood experiences gave the child most of what they needed. Okay, so again, checklist of what that does to a patient and how to think about a patient from the therapist's perspective. A patient comes in and they're high functioning, number one. They're educated, they're productively employed, they have decent long-term relationships. That's high functioning, all right? Number two, they have mature, somewhat rigid defenses. They don't engage in massive psychotic levels of denial about reality. They may have some repression, they may sublimate their conflicts, they may have a variety of these more advanced, developmental appropriate defenses that we all do if we're high-functioning neurotics. And so it isn't the fact that we have defenses, it's that they tend to be more sophisticated, more sort of developmentally advanced, mature, but perhaps a little too rigid. the key is that they have a sense of, and you get a feel for, their integrated identity. They are they are reality related. They do deal with reality in an adaptive way. They do get their problems dealt with, for the most part, in a way that works in reality. They do have the therapeutic split. That's that ego-alien, ego-syntonic thing, that they are capable of working with the therapist about the problem they see they're bringing in. It's not the problem that the evil people are persecuting them about. It's not the problem that their wife or husband is forcing on them. It's they're bringing something to the table, and they realize it. And the therapeutic split is this ability to enter into a healthy therapeutic relationship with the therapist to deal with that problem. What's the countertransference to the therapist when a patient comes in and sits down and they're high functioning? When I see a patient come in and sit down, and we have a first clinical hour, second clinical hour, third clinical hour, and I sort of, at the end of the second or third hour, I sort of pay attention to my reaction. If my reaction is sort of benign, if I sort of like them and they seem like reasonable people, or if I see that there's a problem, but it's not extreme, then I have a sense that they're in the high functioning category. A benign countertransference, a sense of the patient is mostly there, mostly coherent, and that their problems, or my reaction to them, good and bad, is not very extreme, is that they're sort of within fairly narrow parameters. That's an indication to the therapist that you're dealing with a high functioning person. Okay, next step down, borderline. They are fixated in dyadic struggles between total enmeshment, which they feared would obliterate their identity, and total isolation, which they equated with traumatic abandonment. All these words come from child development. Okay, so when you start out as a baby, you're in a symbiotic relationship with the mother. The baby at 1 week old cannot tell the difference between itself and its mother. They're symbiotically joined psychically. The baby has no sense of itself as a completely separate person. I think that's obvious to most people. Okay, then at about 6 months, they enter a phase of development where the baby and the mother still feel like they're in symbiosis, a symbiotic phase, where there is outside, there might be a father or siblings, there might be others, but the mother and the baby remain in this symbiotic kind of a cocoon in terms of how the baby feels about it, at least. And that's where the borderline gets fixated. They're fixated in that place where they haven't quite done the separation individuation work yet. They haven't achieved that object constancy. They're no longer completely in symbiosis. They're no longer in a place where they can't tell the difference between inside and outside, but they're in that middle ground, and they get stuck there because of some developmental derailment. What does that mean in terms of how the therapist sees them coming through the door? Primitive defenses. Now, they have some ability most of the time to deal with reality, but they have, around the question of primary relationships, the tendency to use very primitive, psychotic levels of denial, massive projective identification. We'll define some of these more clearly a bit later. And an additional criteria that I think is central to the diagnosis of a borderline type personality is that after a breakdown, after they have had some experience of sort of identity fragmentation, again, usually around the threat to a key relationship, they seem to not get what just happened. They have what McWilliams calls a relentless denial of pathology. They will blame others. They will blame the therapist. They will blame sometimes the therapist. They'll blame the partner. They will not look clearly at their own participation. And that, to me, is one of the key differences between neurotic functioning, high functioning, and borderline functioning. Second, more subtle indicator, this would be fourth on the list here of characteristics of the borderline, they have little tolerance for ambiguity or ambivalence. A borderline person is a black and white thinker. It's all or nothing, good or bad. Very frequently what you find is they will simply, sometimes they'll blame themselves. I think that happens sometimes. But for the most part, they will project the bad parts of themselves into the outside world somewhere, and things remain quite split. Splitting is the defense, the primitive part of splitting used by a borderline type to separate out their own experience of good from bad. And that bad stuff has to be put out there. During that fragmentation phase, what we find is the borderline splitting. And if you bring that up to a borderline patient, they will very quickly deny any possibility of sort of complications or their own participation. And that's a key indicator diagnostically of where they are. That has ramifications for the therapist, because the therapist has to be very careful. Sometimes interpretations that reveal some of that ambiguity or reveal some of that responsibility or suggest to the patient that the patient, him or herself, may be part of the problem, gets felt as a very aggressive, hostile attack by the patient. That'll blow up therapy in a minute. They have a tendency to flood, and that means they get overwhelmed with these intense emotions. That's what evokes the breakdown, is that they cannot, their identity isn't strong enough to contain this wave, this flood of intense, dangerous emotion, and they fall apart. And so it's critical for the therapist to diagnose accurately, because that means your interpretations have to be titrated, have to be careful, have to be couched in sometimes very gentle language around the edges of the pathology, just to explore the possibilities here. You go straight in thinking you've got a high-functioning neurotic with an identity that's strongly integrated. You may then sort of risk a more intense, a more anxiety-provoking interpretation to try to get out a little bit more of the psychic reality of the patient. But if you've misdiagnosed and that person has some borderline dynamics, you might evoke even a bit of a psychotic breakdown. You can certainly evoke a very hostile reaction in a patient. They will flood, and they will split, and they will attack if they feel attacked themselves. Okay, bottom of the structural axis, psychotic. McWilliams describes them as fixated at a fused pre-separation level in which they could not differentiate between what was inside and what was outside themselves. This is the classic symbiotic stage. The classic, even before that, you could argue, even almost a recreation of the prenatal existence, the oneness of the mother and the child from the baby's perspective. Some have called it the autistic phase, but that's a bad bit of language, I think. It's more this absolute oneness. But if that's where the patient is fixated, then they've never even gotten to the point of differentiating inside from outside. At least in the regular symbiotic phase, where the child is still sort of in this oneness experience with the mother, they still have a sense of what's on the outside. They still get the difference between outside the symbiotic experience and themselves. The psychotic doesn't have that. And that's, I don't think anybody who is themselves neurotic or high functioning or fairly well integrated, I don't think anyone, unless they themselves have had a fairly profound breakdown, can appreciate the pain of a psychotic. If you look at a schizophrenic, a homeless schizophrenic, and there are plenty of those, if you look at them, you look closely, what you see is terror. What you see is fear. What you see is dire confusion about what's going on within them and outside of them. They are immensely desperate people, disorganized, and that's terrifying. Their hallucinations and delusions, the key diagnostic criteria for psychosis in both psychodynamic and descriptive theories. If they have hallucinations and delusions, the function of those things is to protect them from all of these horrible emotions. Hallucinations and delusions function for the schizophrenic, for the psychotic, as a defense against the most terrible feelings imaginable. They are fragile in ways that sometimes make them dangerous, not often, but should caution people. Don't walk up to a homeless schizophrenic in downtown Seattle and start chatting them up and try to get to know them. You may be interpreted as some sort of monster trying to attack them, and they may respond with aggression. Be careful. Understand their mind. Understand how distressed they are, how functionally they're not really a self all the time. And if you can wrap your mind around that even a little bit, and the only way you can do that is if you yourself have had a bad moment, and that little bit of experience will give you a hint as to what it's like on the inside of a psychotic skull. So be careful. I think what I agree with McWilliams on the idea that psychotics don't even know that they exist. They don't even understand the idea of existence that most of us just take for granted walking around. They have almost, you could call it profound existential questions about their right to exist. Should they even be there? Who are they? Who are they is an existential question, but to them it's catastrophic and fundamental. And so the simple fact is, if you've got overt psychotic symptoms, the odds are you're not going to show up to a therapist's office because you don't have a concept of time, and you don't have a concept of identity sufficient to tell the difference between yourself and the therapist. And so the sad truth is, folks with the most severe mental illnesses often are the ones who get the least help because the system isn't designed to get them that help, and there frankly isn't enough money in the world to pay for the kind of therapy these folks would need given their numbers and severity. But that's reality. So, again, looking, sort of stepping back, panning back to the entire spectrum, we have some therapeutic implications to this. And I would add, if you're a layperson, there are some relational implications to this. We have a necessity to assess the structure. We must almost immediately, as clinicians, and I think as people, be able to tell the person we're talking to, are they crazy? Are they unstable? Or are they mostly together? If the people are mostly together, then you can continue the conversation. If you get a sense that there is something borderline about this person, it's time to move on a little bit, if you can. I don't think anyone doubts for a moment that when they're in the presence of a psychotic, something is dramatically wrong, and the odds are they shouldn't be there, unless you're a clinician. So structural diagnosis is about formulating an appropriate therapeutic intervention. It's about the prevention of problems. You have to learn how to intervene properly depending on structure. If you don't get that question right up front, you can very likely precipitate, at the very least, the destruction of the therapy, if not direct problems with the patient's life. We do get to recognize that these aren't labels. They aren't categories that anybody fits in cleanly all the time. Even our neurotic, who's mostly together and integrated, under enough pressure can fragment, can fall apart, even for just a momentary experience, and then usually very quickly gets back. We're not in these categories in any ironclad sort of way. The question is one of tendencies, of primary location on the axis generally. That's what's essential to know. You will see movement in therapy. One hopes that if you're in the borderline category getting therapy, that the whole point of therapy is to move them up that axis, to structuralize their identity, to have a therapeutic experience that gives them that sort of integrated self-experience. As part of a therapeutic intervention, if I'm dealing with a severely disturbed person, I'm much more likely to be conversational, even attempt to educate a little bit, to talk to them in ways that feel more natural, less technically therapeutic. You've got to establish a healthy relationship, and you've got to be accessible if you're a therapist dealing with someone in a more severe category. Forming the relationship is different. And again, this is where the medical model and the DSM differ quite a bit from the psychodynamic model. A medical model clinician is looking at the patient's symptoms. A psychodynamic clinician is looking at how to form a relationship. A very different clinical task. Very different. Even good doctors know they have to have a certain bedside manner, but it's their technical expertise and their scientific knowledge and their ability to acquire data that makes them excellent physicians, though bedside manner is important. In psychotherapy, it isn't about bedside manner, it's about the nature of the therapist's ability to be in a deep relationship. And if the therapist isn't, because they haven't done their own work, then the clinical work cannot be done efficiently and can be disastrous if the therapist is sitting in front of a borderline, much less a psychotic patient or a patient with those tendencies. Countertransference. How does the therapist respond? To a neurotic, I respond generally with care. I'm interested. I can fairly easily exercise benevolent curiosity. I can fairly easily hold my opinions. I can have negative capability. I can wait and sit with that not knowing and let things sort of firm up a little bit. I tend to care about a neurotic because there's a relationship there that forms fairly naturally. If I'm with a borderline type, then the extremes can be quite disturbing. One notices precipitous or aggressive splits. A patient will shift quickly, will go from thinking you're the best therapist in the world to thinking you're a disaster. You go from Prince Charming to a demon from hell, within one session. There's almost a standard joke now, a cliche in my field. Therapists hate to hear from the patient, "Oh, Mr. Bigelow, you're the best therapist I've ever heard about." Because we know that's a function of a split. We know that's, it's not true. We're not perfect. We're not omniscient. We aren't the greatest thing since Freud. Everybody knows they've got limitations. And that kind of praise from a patient is a function of the patient's splitting and perhaps borderline functioning. If we hear that, it makes us nervous because we know that the slightest mistake we made is going to plummet us from idealization to devaluation completely. And we're going to go from Prince Charming to a demon from hell, and the patient's going to blast us with that. So, and can do it very quickly. So that's, if you feel those sort of precipitous mood swings in a patient, then you have what I think in the therapist is very strong and unambivalent emotions. Therapists do not like working with borderline patients. It is unpleasant. It is sometimes disruptive. Borderline patients will call you a lot after hours. They will come to your office when they're not scheduled. They will make complaints. They will harass you sometimes if it gets quite ugly. These are folks that therapists, by and large, will refer out to someone else unless they're very well trained or can tolerate a great deal of difficulty themselves. What's a little ironic is most therapists' reaction to psychotics. Unless they're hostile and aggressive, most psychotics evoke in the therapist kind of a wonderful attachment, that there's this very early feeling of oneness that can be quite wonderful. It can also be all absorbing. It can be you can almost lose your own identity in the process because that's what the patient is experiencing. They are, as McWilliams says, terrible in their needs. They need in some absolute way. And a therapist's tendency, because we tend to be compassionate people, Often with a psychotic or someone with psychotic processes, very often will get sucked in to dynamics that aren't very therapeutically effective, that patients who are psychotic convince, or therapists convince themselves that extreme measures are often necessary, and that can become quite troubling to the therapist and unhelpful to the patient. The thing I want to point out, I think most directly, is that we now have this inflation of language in the psychodynamics field. The borderline category has been so radically expanded, I'm not sure it has much actual meaning anymore. Anyone with trouble seems to be labeled borderline, and it's gotten a certain negative valence in my community. If a clinician describes a patient as borderline, everybody goes, wow, that's too bad. Okay. So again, a label does not equal knowledge, and one has to step back and keep in mind the whole person. And I think that's true wherever they are on McWilliams' structural axes. Okay, to summarize. Let's summarize 5 or 6 ways of thinking about each of the categories, from psychotic, borderline, and neurotic. What is the central preoccupation for a psychotic? It's security. What is the central preoccupation for a borderline? It's autonomy, that's that pull in symbiosis. What's the central preoccupation for a neurotic? It's a sense of their growing and complex identity. This is all coming from page 68 of McWilliams' text. In the last chapter, the last paragraph of chapter 3, she tosses off in one paragraph these sort of juxtapositions, and this is material that's rich enough. It's worth an entire chapter itself, it seems to me. But if you can keep some of these ideas in mind, these are not footnotes, but they're just, okay, they're labels maybe, and that's dangerous, I get that, but these are I think intellectually or theoretically really useful little things to hang your hat on. All right, what's the central preoccupation of a psychotic? It's security. They're threatened, embattled. Right? A borderline, autonomy, relationship issues. For neurotic, identity. Okay. What are their characteristic experiences of anxiety? For the psychotic, it's annihilation. They're constantly on the verge of experiencing annihilation. For the borderline, it's loss, separation. They're going to be the abandonment dynamics, possibly engulfment, possibly losing their identity in that relationship or its abandonment. Painful stuff. What does the neurotic feel about his anxiety? How does he experience anxiety? And it tends to be about punishment, injury, loss, guilt, I think. A very high functioning, complex experience of anxiety. What is the developmental primary conflict? We've talked about this. In the earliest phases, the ability to tell the difference between inside and outside. Separation, individuation in the borderline. The ability to separate out from that symbiotic oneness and its dangerous and catastrophic feelings associated with it. For the high-functioning neurotic, the developmental conflict is the achievement of the Oedipus complex and its resolution in a healthy way. That should make sense if you've looked at the other material. One way of thinking about it is their object relational capacities. Object relations. How do they relate? To a psychotic, there is no relating, hardly at all. Monadic. There's just the experience of the psychosis and its fragmentary nature. Inability to tell inside from outside, therefore, inability to be in much of a relationship at all. So, monadic. Dyadic. To the borderline, it's always about the primary relationship. Other people don't really matter very much. It's all about this. If you get a patient and all they want to talk about is their love relationship, all they want to talk about is their key relationship, and nothing else seems to matter, that's an indicator of borderline functioning. For the neurotic, relationships are triadic, meaning complex. There's more than two people involved. More than two people involved in most of their relationships. They have the ability to get beyond the Oedipal dynamic of the conflict of the third and accept that third and therefore accept others. Relationships with high-functioning neurotics, you tend to hear stories of multiple relationships at different levels. That's an indication of high-functioning neurotic structure. What is the sense of the self? What is the sense of a psychotic self? And the simple truth is, a psychotic doesn't have much of a sense of self. To the extent there is one, it's embattled, it's persecutory, it's fragmented, it's struggling, it's dangerous, rather painful. To the borderline, that's the embattled self. That's the struggle of abandonment versus engulfment that never quite got resolved in the separation individuation phase. What is the sense of self of the neurotic? He or she is responsible. They take a great deal of individual responsibility. I want to add one point that I probably left out earlier. That is also one of the great differences between the dynamic and the medical model of psychopathology. The danger in the medical model is the stripping away of individual responsibility. People have a tendency to want to medicalize their mental illness. There is a tremendous push to find brain function as the reason for people's behavior. Give them a drug. Give the ADHD boys Ritalin and its derivatives. Calm them down. They have a brain chemistry problem. No, actually they don't. What they have is a relational problem, a self problem, a structure problem, an anxiety problem. There is no direct scientific connection between brain chemistry in any particular formulation and human behavior. And this is one of the central conflicts in psychopathology theory. If you gravitate toward a medical model, you strip away adult responsibility or even adolescent responsibility for behaviors. If it's a function of brain chemistry, then I'm not responsible for doing what I did. That in psychodynamic thinking is destructive, is not helpful, does not move a therapeutic relationship forward. If all I need is to change my brain chemistry, then I certainly don't need to take any personal responsibility for my behavior or its effect on others. And really all I really need to do is take psychotropic medication and everything will be fine for as long as I live. That's a disaster. And I think anybody who's been in this field more than 3 weeks knows that if your approach to psychotherapy is to medicalize human behavior across the board, then though I get there may be a significant minority in my field that suggests the way to better mental health is through chemistry, I find most competent clinicians recognize that there's something going on in the identity of the person, in the sense of self, in the structuralization of their mind, which cannot be understood in terms of brain chemistry or genetics, at least yet. In chapters 5 and 6 of the McWilliams text, she outlines, I think, the most thorough discussion of individual defense mechanisms. We've discussed the structure of the mind, and we're going to move in the next set of lectures into the defensive style within that structure. We're going to be able to put any patient or you somewhere on that chart, not with a pinpoint, not with perfect accuracy in any scientific way, but in the context of an area where you tend to gravitate, some along one of the axes, along the structural axes, and along the defensive styles. In order to understand McWilliams' defensive styles, you've got to understand what she means by the various defense mechanisms. And I have never seen a more thorough list, or a list more specifically, carefully explained with great clinical examples. So I'm not going to go over those again. I've covered them sufficiently in the in the basic introduction to psychoanalytic theory, and I will touch on them as we move through Dr. McWilliams' horizontal chart. There's so many that it would be a bit tedious to go over the details. If they become necessary to understand the specifics of the horizontal axis, I will explain them during that part. Right now, we're done with this section, and we'll next, in the next video, move forward into the defensive styles of the horizontal axis. Thank you very much. How long was that?